Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. Today we'll be talking about fibroids or leiomyomas. So in our lecture today, we'll look at the definition of what fibroids are, the risk factors of fibroids, the pathogenesis associated with the condition, the different locations to which these fibroids can be found, the natural history of the disease, some clinical features. We'll look at the diagnosis and some investigations that you may order. We'll look at the management, and then we'll end off by looking at the different complications associated with fibroids. Remember that these fibroids can also be referred to as myomata, or you could call them fibromyomata. Other people can refer to them as leiomyomas. They all mean the same thing. So this is actually going to be one of the most common benign tumors that's going to be affecting the uterus. And in the epidemiology of the condition, we actually see that it affects more Black individuals than it affects white individuals. So a Black individual is 5 times more likely to develop fibroids than a white individual. Again, when we look at the age range of this tumor, it's going to be affecting people between the ages of 30 to 50 years. The reason being, these are the reproductive years, and there's a lot of estrogen, and this is an estrogen-driven tumor. That means it's also going to be common in nulliparous women as well as women who have one-child infertility. On the other hand, fibroids have also been seen to be very common in obese women. The reason being, adipose tissue has the ability to synthesize a type of estrogen which is referred to as estron, and this estron, of course, is going to be driving the formation or driving these tumors. Some risk factors are going to be either modifiable or non-modifiable. Now, with the non-modifiable risk factors, meaning you can't really do anything about it. You can't do anything about your family. You can't do anything about your genetics. So a family history has been shown to predispose individuals to developing fibroids. It could be either a first-degree relative, a mother, a sister, or even a daughter developing fibroids. Then there could be an age between 30 to 50 years. That's where they're much more common. And of course, there's a predilection for African racial origin, meaning it's 5 times more common in Black individuals than it is in white women. Now, on the modifiable risk factors, things like nulliparity, as I already explained to you, which may increase the estrogen exposure, obesity, which is going to increase the production of estron, which is a form of estrogen. Then polycystic ovarian syndrome is also going to be associated with these imbalances in estrogen. And you also have other hyperestrogenic states, which could be through exogenous estrogen intake, or even other tumors that could be producing estrogen could drive the production of fibroids. Now, funny enough, I know this is going to raise a lot of eyebrows, and I'm not advocating for smoking, and I'm not encouraging women with fibroids to start smoking. Or I do not want you to tell your patients, oh, go smoke, it's going to reduce fibroids. But what we have noticed is that there's actually a decrease in the development of fibroids in people who smoke versus people that do not smoke. But the dangers of smoking greatly outweigh the benefits. Some dangers that I could actually get from the top of my head include things like atherosclerosis and ischemic heart diseases, hypertension. It could lead to different things like strokes. It could lead to cancer such as an oropharyngeal carcinomas. It could lead to esophageal cancers. So please do not start smoking in an attempt to reduce your fibroids or to reduce your chances of developing fibroids. Multiparity, on the other hand, also protects individuals from developing fibroids. So the more you're pregnant, most of the hormone that's going to be predominant will be your progesterone and not really your estrogen. But someone who already has fibroids and decides to get pregnant may undergo certain changes, that which I'll talk about, one of them being red degeneration of the fibroids, which can actually present as a very painful scenario. Now, we don't really know what exactly is going to be causing these fibroids to occur, but what we assume, or what is believed, is that you actually have a single smooth muscle cell that becomes neoplastic and then develops or starts growing out of proportion and grows into this tumor. So these tumors are referred to as monoclonal tumors because they're going to be arising from one single smooth muscle cell. The stimulus that can actually transform this tumor to it becoming neoplastic, we don't really know what causes that, but what we assume, or what we have seen, or what is evident, is that these tumors are pretty much dependent on estrogen. Sometimes this tumor may form what is referred to as a pseudocapsule, where it's going to be compressing the surrounding uterine structures. And this is actually very important because once you're doing your myomectomy, it makes it easy for the fibroids to be removed as a whole. Now, some of the evidence that may actually point us towards why we say this tumor is estrogen dependent include things like when you are during your childbirth periods, when there's a high level of estrogen, that's where you have the greatest growth potential. So meaning that after menopause, the growth stops. The second thing that is pointing us towards these tumors being estrogen dependent is the fact that they tend to increase during pregnancy. So they may undergo certain changes, like I said. They may undergo a red degeneration during pregnancy where they become painful. Sometimes these tumors are going to be expressing more receptors that are going to be containing more estrogen receptors than the uterus that is surrounding. And of course, we do not see these tumors before menarche, and after menopause they usually do not grow, and you don't form any new fibroids after menopause because estrogen won't be there unless a woman is receiving estrogen from elsewhere. Then of course they are frequently associated with anovulation. So these are some of the factors that are going to be pointing us towards us believing that these tumors are estrogen dependent. Now, when it comes to the natural history of the disease, remember that these are going to be changes that are going to be happening in the size of the fibroids that happen during a woman's different stages of reproductive age. So generally the fibroids are going to be these slow growing tumors. So when they're growing slowly and they are small, these become asymptomatic, or they do not have any symptoms. Now, they may undergo certain rapid growths, and they may actually increase the number of estrogen receptors that are present during certain phases, such as pregnancy. Then they may also, as they grow, they may now outgrow their own blood supply, and then when they outgrow their own blood supply, that's going to result in ischemia, and they'll develop what is referred to as ischemic degeneration. Now, this degeneration is of many types, but the most common types that I want you to know for the sake of your exam are hyaline degeneration, cystic degeneration, and red degeneration. So one of the most common being hyaline degeneration. So here in hyaline degeneration, where you have this blockage of this blood supply to the fibroid, because this fibroid is growing faster than the blood can actually maintain, or the blood can keep up. So here you're going to be having this atrophy within this with the loss of muscular components, and there's going to be actually hyaline generation in the fibrous tissue elements. Now, if the blood supply or this fibroid is still not receiving enough blood supply, then hyaline degeneration can progress to become cystic. So the center of this fibroid will actually become ischemic. It will undergo degeneration and it will become cystic. So it may give you this honeycomb appearance, and you refer to that as cystic degeneration. Now, in some cases, especially during mid-trimester as well as in the preperium, just after a woman gives birth, the first 6 weeks, so you refer to that as the preperium. So sometimes this fibroid can actually undergo this acute disruption of its blood supply, especially when it's during its active growth phase. So when it's during its active growth phase and its blood supply is interrupted, then this fibroid may actually become very painful. So you have this localized tenderness over the uterus. You may have this fever. Sometimes you may even have this white blood cell count increase, which is known as leukocytosis. Then the fibroid is said to undergo red degeneration. This is very common in pregnancy. Now, how we manage this, we usually just advise the patients bed rest, and we can give them some narcotics to help with the pain. Then additionally, the fibroids could actually calcify, but this is much more common in postmenopausal women. And of course, they are going to shrink as the levels of estrogen fall beyond menopause, or sometimes you can medically induce this shrinkage by giving someone gonadotrophin releasing hormone agonists that are going to suppress the production of FSH, thereby reducing the levels of estrogen and thereby reducing the size of the fibroids, because estrogen won't be there to drive these tumors. Now, these tumors could be found in two main areas. So they could be found in the body of the uterus, or they could be found in the cervix. Now, here's a diagram on the left of your screen, which is showing you the uterus over there with different types of fibroids. So here we have your broad ligament over there, you have your fallopian tubes over there, you have the uterus over here, you have the cervix over here, and of course this is leading to the vagina. So the fibroids that are found in the body of the uterus, you could refer to them as corporal fibroids. So they could either be found inside the wall of the uterus, you refer to that as interstitial or intramural type of fibroids. These are going to be accounting for the majority of the fibroids. 75% of these are going to be interstitial or intramural, so within the walls of the uterus. Some of the fibroids could be just underneath the serous layer, so you call them as the subserous layer, just underneath the peritoneum. Okay, subserous layer. These are going to be the second most common type. Then sometimes they could be just underneath the mucosa of the endometrium, so you refer to those as submucosal type. So you have three main types: your interstitial, your subserous, your submucosal. All these are found in the body of the uterus. And then the subserous could either be wandering, they could be part of the broad ligament, they sometimes could just be subserous. I shall explain that a bit later on. Then the submucous could either be sessile or they could be attached by a stalk, and they could be referred to as pedunculated. So all these are just pretty much going to be found in the body of the uterus. While on the other hand, they could be found in the cervix, where they could be anterior, posterior, central, or lateral. So beginning with the intramural type of fibroids, like I say, these are the most common, so they're going to be accounting for 75%. They're going to be found within the uterine wall. If this fiber is actually pretty small enough, they are going to be asymptomatic, so they won't have any symptoms. And when you examine this patient, you may not be able to pick up anything. But actually, when they begin to enlarge, they may actually distort the uterine contour, the external contour of the uterus. They may actually distort the venous drainage, so they are going to tend to bleed a lot. And whenever you have these heavy menses, you refer to that as menorrhagia. Then sometimes you may have a subserous or a subperitoneal type of fibroids. These are the second most common. They account for about 15%. So these are just going to be below the serosa, just below the peritoneum. And they're usually going to grow, and when they grow, they may distort the external contour of the uterus, and they may actually present to you as this firm, non-tender, asymmetrical mass. Sometimes they may become pedunculated, where they are attached by a pedicle, and this fibroid can actually twist, and when it twists, this may actually result in acute pain, and which is going to be due to torsion. Then some of these subserous fibroids can actually grow into the broad ligament. Now, if they grow into the broad ligament and they become either partially or completely covered by peritoneum, but they still remain attached to the uterus by a pedicle, you refer to those as pedunculated serous fibroids. Sometimes this pedicle can actually be torn off, such that this fibroid is now going to be solely just receiving its blood supply either from the omental or the mesentery of the intestines. Then you refer to that as a wandering, or you can call it a parasitic type of fibroid. And remember that sometimes you have these intramural fibroids that can actually push through the layers of the uterus and go into towards the broad ligament. So you don't refer to those as true types of fibroids. They're referred to as false fibroids or pseudo fibroids, or you can just simply call them as broad ligament fibroids. These actually can apply pressure on structures that are surrounding. So they could be applying pressure on the bladder, resulting in nocturia. They could apply pressure on the rectum, even apply pressure back on the uterus. Then the third type, which is a corporal type of fibroid, or the fibroids that are found in the body of the uterus, these are referred to as a submucous fibroid or submucosal fibroid. So these are going to be accounting for 5%. And remember, these are going to be found below the endometrium. So sometimes they may distort the endometrial cavity, and they'll make this endometrial cavity not to be able to respond to certain hormone fluctuations, such that it will keep bleeding. So sometimes you can have this bleeding that is happening in between the menstrual cycle. So you refer to that as intermenstrual bleeding. So you refer to that as metrorrhagia. So these fibroids can also become pedunculated, where they have this pedicle and they form these polyps, and these polyps can sometimes be extruded into the cervix. Now, the last type is the cervical type, which is not so common, accounting for about 1 to 2%. So these could either be interstitial, so within the walls of the cervix, or subperitoneal, just underneath the peritoneum. Sometimes they may also form these polyps, but it's very rare. And of course, remember, they could either be anterior, posterior, lateral, or even central. Now, some of the clinical features are going to be dependent on the history of an individual, and some of the clinical features we're going to see them on physical examination. Now, most cases of fibroids tend to be asymptomatic. So some people do not even know that they have fibroids. It could be an incidental finding where they go to the hospital for something else, then they get a scan and then they are told that they have fibroids, or they get examined and they are told to have fibroids. So 70% actually tend to be asymptomatic. In the people that are symptomatic, they may present you with this menstrual abnormalities, as we have seen, very common with intramural fibroids, very common with the submucous fibroids. So you may present you as menorrhagia, which is this heavy menses. It could be metrorrhagia, which is this intermenstrual bleeding. Sometimes it could be menometrorrhagia, which is this heavy menses and intermenstrual bleeding. So because these women are recurrently bleeding, so they may develop anemia also as a clinical feature. So there may be these palpitations, there may be this lightheadedness, there may be this dizziness. Then you may also get dysmenorrhea, which is this pain associated with menses. You may get dyspareunia, which is this pain associated with sexual intercourse. You may get infertility, especially common with the submucosal fibroids. Because the fibroids are actually within the cavity of the uterus, it impairs the transport of the sperms during the process of fertilization up the uterus. It's not as effective. Sometimes these fibroids could be large enough to block off the fallopian tube such that the sperms cannot get access to the ovum. Again, alternatively, because these fibroids are found inside the submucous area or just underneath the endothelium, then it makes it very difficult for the fertilized egg to implant. Then you may also get some pressure symptoms, especially with the subserous type of fibroids. You could have frequency, urgency, nocturia if you get compression on the bladder. You could have diarrhea and constipation if you get compression on the rectum. Some people may actually experience this lower abdominal, even sometimes pelvic pain. There may even be this abdominal enlargement. Sometimes they may even just feel this pelvic heaviness, kind of like the pelvic organs are pretty heavy. In some individuals, they may get these recurrent pregnancy losses, which could either be miscarriages or through preterm labors. Now, when you examine this patient, you want to perform a general examination where you may see these features of anemia, you may see these varying features of pallor, and you want to do an abdominal examination. So remember, when you're doing an abdominal examination, you're going to pretty much, as well as a pelvic examination, you're going to pretty much compare the size of a fibroid to the size of a pregnancy. So remember that the pregnancy, once a pregnancy reaches the umbilicus, or once the size of the uterus, the pregnant uterus reaches the umbilicus, that's roughly at 20 weeks of gestation. So if the pregnant uterus reaches the pubic symphysis, that's roughly around 12 weeks of gestation. So we usually compare the size of fibroids to the gestation of the pregnancy. So when you perform this physical examination and abdominal examination, you may, if the tumor is not large enough, you may not actually be able to feel it by an abdominal examination. But if it's larger than 14 weeks, meaning it's past the level of the pubic symphysis, then when you palpate, you may actually feel this firm mass. Sometimes it may be cystic during cystic degeneration. Of course, the margins will be well defined. It's a benign tumor. You may not be able to palpate the lower pole because this is a property that is seen with masses that are of pelvic origin. You cannot go beyond the inferior or the lower pole. The surface usually tends to be quite nodular when you palpate it, and the mobility is actually restricted from above downwards, but you can actually move it from side to side. When you percuss this mass, it usually tends to be dull. And then when you perform this pelvic examination, the bimanual pelvic examination, of course, you're going to see a uterus that is irregularly enlarged, and you can feel it per abdomen. Then this uterus is not going to be felt separate from the swelling, and you won't have a groove in between when you're moving the mass and the uterus. It's kind of like they move together, which distinguishes it from other masses that may be found in the adnexa, where if you move the uterus, the mass, you can feel a separation between the mass and the uterus. And the cervix also moves with the movement of the tumor, and you can actually feel this per abdomen. Now, the diagnostic investigations that you may order include an ultrasound. Remember, you could do either a transvaginal ultrasound or a transabdominal ultrasound. So in a transabdominal ultrasound, that's where the probe is placed over the abdomen, or the perineum in this case. Then in a vaginal, you get a transvaginal, you get a vaginal probe and you insert it within the vagina. So it's better for you to get a transvaginal. But in most hospitals, in our setting, we usually do a transabdominal ultrasound. So the reason why you're going to be doing this ultrasound is you want to look at the location of the fibroid, you want to look at the dimensions of the fibroid, you want to look at the consistency of the fibroid. So these are investigation is very important because it can help you visualize these intramural fibroids, which are large enough. It can help you visualize the subserous fibroids. Then you may also do what is known as a saline infusion sonography, though I haven't seen one being done. So what you simply do is you take 5 to 10 mils of normal saline, then you simply inject it into the uterine cavity before you actually visualize the uterine cavity on ultrasound, and you may actually see the fibroid, the submucous fibroid, for example. But it's very, very difficult for you to now distinguish between a subserous fibroid from the ovary or an ovarian mass. So here's a picture of an ultrasound and what a fibroid is going to be looking like on this diagram. So as you can see, there's a mass here in the uterus. Then you may sometimes do a hysterosalpingogram, which is very important in showing you the submucosal as well as the intramural fibroids, and they may be seen actually as filling defects. I didn't have an image for this, so you could just simply Google one and you see how it looks like. You may also do a hysteroscopy where you insert a camera into the uterus and you'll be able to see these submucosal fibroids. But the definitive investigation or the definitive diagnosis should actually be made on histology. So when you actually excise the fibroids and take them to the lab and they are seen under the microscope, and it's confirmed that there's no malignant features. And usually when you examine this tumor on gross examination, so you get this whorled appearance where there's going to be interlacing of the muscles as well as the fibrous tissue, and I'll show you a picture in the next slide. You may also do other investigations such as a complete blood count or a full blood count, which is going to be showing you anemia. You may do a pap smear, you may do an endometrial biopsy, you may do a dilatation and curettage. Of course, that's all to rule out malignancy, because you don't want to leave a cancer in an individual. You want to make sure that you rule that out. So here's a whorled appearance that you can see here of the fibroid. So this was a fibroid that was taken out from a patient. So our differential diagnosis include things like pregnancy, of course do a pregnancy test, ovarian tumors, which could be very difficult to distinguish on ultrasound. You could have adenomyosis, you could have a full bladder, you could have myohyperplasia, and of course you could have a complication of pelvic inflammatory disease, which is known as a tubal ovarian mass, or it could be a tubal ovarian abscess. Then the management, of course, for these patients, for the patients that are asymptomatic, there's no treatment that we need to institute in this patient. So most of the tumors are actually going to shrink after menopause, because there are some patients that have had fibroids that were asymptomatic, then they discovered them incidentally, then they wanted to get them removed, and then complications came about, or some patients have even died because of the same thing. So if they are asymptomatic, please just leave them as they are. There's no treatment that is required. The best that you could actually do is just performing these annual examinations, getting an ultrasound to actually monitor the size, especially in women, because you get worried if this mass keeps growing very quickly, because fibroids do not generally grow so fast. Then if a patient actually becomes pregnant and there's no other complications, sometimes the fibroid may undergo red degeneration, like I already explained. So all you can do is just bed rest and narcotics for this individual. That's all that you can do. Then treatment is usually indicated for the following scenarios. So if the tumor is greater than 14 weeks in gestation, so if it's very large, then you would want to get it removed. If the hematocrit is falling or this patient has anemia, then you should get this fibroid removed, because the bleeding will lead to them become severely anemic and they may die. So if the tumor is compressing on adjacent structures and bringing about symptoms, then you want to get it removed. If it's bringing about nocturia, if it's bringing about constipation or diarrhea, please get it removed. If it's bringing symptoms that are going to be limiting your lifestyle, like for example excessive bleeding whereby you can't even leave home, get the fibroid removed. So the treatment that we usually offer patients that come in with fibroids could either be medical and surgical. So the definitive treatment is pretty much the surgical, and it's going to depend on the desire of this woman to retain this fertility. So what can we do for these patients medically? We just usually aim at the pain as well as the bleeding. So if this person is bleeding or has started this menstruation, you could give them tranexamic acid, about 1 gram 3 times a day for up to 4 days. Remember that you should give a maximum of 4 grams per day. And you want to rule out conditions such as disseminated intravascular coagulation. You want to rule out convulsions. You want to rule out any thrombotic diseases or any thromboembolic disorders, because you don't want to give someone tranexamic acid and their blood will end up clotting. They may develop other complications. If they are in pain, you could of course give them some NSAIDs such as mefenamic acid, given orally about 500 milligrams 3 times a day. You can also give them oral combined contraceptive pills. And funny enough, though we do not use this as standard treatment because it causes endometrial hyperplasia, some antiprostaglandins such as mifepristone in very low doses can actually cause a fibroid to shrink, but we do not currently use them because they're going to cause endometrial hyperplasia. Then the surgical treatment that we can offer these patients before we actually take them to theater to get the fibroids removed, we could actually give them a gonadotrophin releasing hormone agonist such as leuproride, and we're going to be giving these patients for about 3 to 6 months in an attempt to shrink these fibroids, so that when we shrink these fibroids and this person goes for surgery, then it's easy to remove the fibroids and they do not bleed as much. But of course this isn't routinely done for all the patients. Then the surgical procedures that we can do are pretty much either a myomectomy or a hysterectomy. And remember, these depend on whether the woman wants to have children again or she does not want to have children. So if the woman actually has infertility and this infertility is not attributed to any other cause but possibly the fibroids, of course get the fibroids removed. And in about a third of the patients, they actually tend to recur. Now, if you make an incision when you are removing these fibroids and it actually enters into the endometrial cavity or the uterine cavity, then it means that all the other pregnancies that this woman is going to be having are going to be via C-sections, because there's going to be a high risk of uterine rupture if this woman was to actually give birth vaginally. Then the other thing that you may do in women that have completed childbearing age and maybe the fibroids are large, you can perform a hysterectomy. If the fibroids are very large, this woman is above 40 years and she has multiple fibroids, you can perform an abdominal hysterectomy. If they are small and if the fibroids are quite few in number, and if they're even associated with prolapse of the uterus, you may perform a vaginal hysterectomy. Now, there's another procedure that could be done which is referred to as embolization. So here, this is this radiological procedure where you're going to be getting this catheter. You're going to be inserting this catheter in the vessels that are pretty much going to be supplying the fibroids. So these can be actually passed in the uterine arteries via the femoral artery. And then what you're going to be injecting in those are these silicone particles, which we refer to as microspheres. So these microspheres could actually cause ischemia. They could cause necrosis to the fibroids. So that's one way of dealing with the fibroids. But of course, this is not advised for patients that want to retain fertility. But in some cases of people that have actually gone embolization, they have actually given birth despite them getting this procedure. But please do not do this procedure if the woman wants to preserve their fertility. Then generally with this procedure, you preserve the uterus, but at the expense of having this patient having some considerable number of pain. So in women with these large and even multiple fibroids, there's going to be a risk of hysterectomy. So you'd rather do them surgically. You treat them surgically rather than performing embolization. So there may also be a risk of developing pyrexia as well as abscess formation. The different complications that are associated with fibroids include things like severe anemia because of the chronic bleeding. There may even be polycythemia as a complication of the tumor itself. Sometimes there may be some severe intraperitoneal hemorrhage. There may be severe infections that may be there. Sometimes there may be infertility that may be there. There may be some pregnancy-related complications, which are going to be including things like abortions, first trimester bleeding. It could be preterm labor. There could even be labor dystocia. There could be breech presentation because this fibroid is within the uterus and the child cannot really find itself in the correct position. Sometimes there's going to be an increased risk of operative delivery. So suppose you're performing a C-section and you realize that this woman has a fibroid. Please do not remove the fibroid at that time of the C-section, because once you remove the fibroid, remember that this fibroid may have undergone red degeneration, and once you do that, there's a risk of this woman going into severe hemorrhage, and there's a risk of actually a hysterectomy being done on her. So wait until after you have done the C-section, then you can take back the patient to the theater if they so wish to get the fibroids removed. You may also get this intrauterine growth restriction because there's not enough space for the child to grow within the uterus. It's kind of like competing with the fibroids. You may also get this postpartum hemorrhage because the uterus is not going to be able to contract as efficiently. So just a sidebar to mention about the other side of the coin, you may get this entity, this malignant tumor, which is referred to as a Leomyosarcoma. It is extremely rare. Extremely rare. We never say never in medicine, but it's extremely rare for a fibroid to actually become malignant, to become cancerous. So in most cases of leiomyosarcomas, this is just pretty much a malignant proliferation of smooth muscle cell that's going to be arising from the myometrium as well. And they usually arise de novo, meaning that the leiomyomas do not necessarily become leiomyosarcomas, or they do not become malignant. So we see these leiomyosarcomas as common in postmenopausal women, and usually they are single lesions that may undergo necrosis. They may even undergo hemorrhage. And when we look at it on histology, we see a lot of mitotic figures or a lot of mitotic activity. We also see some cellular atypia. So usually this is going to be treated depending on the staging of the condition, but generally you want to remove the cancer. With that said in mind, from MK Medical Review Series, thank you for taking your time to listen to this lecture on fibroids. Until next time, bye-bye.